Hello guys, welcome to my channel. So today we will be discussing an important topic. So that is your stomach cancer or gastric cancer. Okay, so let's start with some basics. So like the anatomy. So the stomach, as you know, is a muscular organ which is helping in your protein digestion mainly, and it is consisting of the cardia, the fundus, the body, and the pyloric antrum and the pyloric canal. Okay, and so in Western countries, the stomach cancer is going to be more common in the proximal stomach near the GE junction, that is your gastroesophageal junction, whereas in Asian countries, it is more common in the distal stomach. So if we come to the histological layers of the stomach, so we have the mucosa, then we have the submucosa, and then the muscularis, we have the subserosa and the serosa. So if you come to the gastric stomach, it is the fourth most leading cancer in the world, and the second most common cause of death due to malignancy. Okay, so today it is more common in Asia, your gastric cancer, and in India it is comparatively low as compared to the West. And among the males, the most common cancer is going to be your lung, followed by your prostate, colorectal cancer, and finally your stomach. So it's fourth most common, whereas in females the most common is breast, then we have cervix, colorectal, lung, stomach. So in females it is the fifth most common, and overall it has a poor prognosis. And in India the highest incidence is in Kashmir, which is around 36 per 1 lakh, whereas in Chennai it's around 15 per 1 lakh population, and in Bangalore it's around 10.6 per 1 lakh. So around 40 to 50% of these gastric cancer cases, they present at an advanced stage. They'll be inoperable at presentation, so you can give only systemic therapy. So coming to the risk factors for your gastric cancer, so we have the nutritional risk factors. So we have the salted or smoked meat or fish, okay, so in which has been implicated as a risk factor. Then we have low intake of fresh fruits and vegetables, that has been implicated as a risk factor, and high complex carbohydrates and a low fat or protein consumption have been implicated as risk factors. Among the occupational risk factors, we have the rubber workers, coal workers, zinc, lead, talc and asbestos workers who are more prone to get gastric cancer. So environmental factors, we have the poor food preparation, that is you either use smoked or salted food, and the lack of refrigeration, poor drinking water, and smoking. So smoking is an important factor. And medical factors, like previously only undergone already a gastric surgery, a partial gastrectomy, subtotal gastrectomy, then that is a risk factor due to bile gastritis because of bile reflux. And then we have Helicobacter pylori infection, which is a very common cause of your gastric ulcer, so it has also been implicated in gastric cancer. And then we have the gastric atrophy and gastritis, which has also been associated with gastric cancer. Then we have some hereditary factors for your gastric cancer. So hereditary diffuse gastric cancer syndrome is there, which is associated with the CDH1 gene, which is a high penetrance gene, and it is associated with the protein E-cadherin. So there is loss of E-cadherin protein in this mutation of the CDH1 gene, and 80% lifetime incidence or risk of developing your gastric cancer if you have a CDH1 mutation. And familial adenomatous polyposis, that is your FAP, which is associated with the APC syndrome, or you can have your other variant, that is the MUTYH gene. Okay, so in this 10 to 20% risk is there of gastric cancer. And then we have the duodenal polyps, Lee-Fromini syndrome, which is your P53 mutation, that can also be associated with gastric cancer. Then we have Lynch syndrome or your HNPCC, it is also called as hereditary non-polyposis colorectal cancer, so that can be associated with your gastric cancer along with colorectal cancer. So it is associated with your mutation of the MSH2 and MNH1 genes. And other generalized some risk factors for gastric cancer is your male gender. Then we have your pernicious anemia because of your achlorhydria associated with pernicious anemia, and we have proto-oncogene overexpression like your CMET, KSAM and ERBB2 genes. These have been implicated. And if you have P53, P16, which are tumor suppressor genes, if they get inactivated, then you're going to get gastric cancer. So what are the precursor lesions? So we have the chronic atrophic gastritis, which is a precursor lesion. Apart from that, we can have some intestinal metaplasia, peptic ulcer disease, Menetrier's disease, adenomatous gastric polyps, and stomach remnants. That is your previous gastric surgeries. These are all your other precursor lesions. Now coming to your Helicobacter pylori, which is a common bacteria which is colonizing your stomach and associated ulcer as well as your gastric cancer. So your reservoirs primarily for this H. pylori is going to be your humans, your primates, cats, and your sheeps. And gram-negative spiral bacillus it is, and 50% of the world population may have your H. pylori colonization. 90% of the people with ulcers, if you consider, they will have H. pylori, and it grows at pH of around 4.5 to 9, and most common site of colonization will be the antrum of the stomach. So how does it actually cause your gastric cancer? So if there is diet low in vitamin C, E, and high salt diet, as already we saw in the dietary factors, there is low vitamin C, E, and your salted diet along with your H. pylori will convert the normal mucosa to chronic superficial gastritis, and that is with respect to your H. pylori's CAG-A gene, which is the responsible for the virulence. Then we can have chronic superficial gastritis, which eventually lead to atrophic gastritis, and finally intestinal metaplasia, and which will lead to dysplasia and cancer. Okay, so for this intestinal metaplasia to become dysplasia and cancer, some mutations are involved, like your P53 mutation and your overexpression of CDX2 and cyclin D2, and if there is some microsatellite instability or decrease in P27 levels.